So we're going to talk about the integumentary system. This system includes the skin, hair, nails, sweat glands, and sebaceous or oil glands. We are going to talk about different disorders of the integumentary system, your cues that you might see patients come in with, nursing interventions, treatment options, and then different education that you would want to provide to your patient. These are your learning objectives for this lecture. Okay, so we're going to do a brief overview of the anatomy and physiology of the integumentary system. Most of you guys got this information in anatomy and physiology, so we understand a basic understanding of what makes up our integumentary or skin system, but I just wanted to talk a little bit about the structure of the skin itself. So the skin is made up of 3 different layers. There is the epidermis, which is the outer layer of skin, the dermis, which is the middle layer of skin, and then the hypodermis or subcutaneous layer. This is the deepest layer of skin. A little bit about each of the structures. The outer layer or epidermis is that thin layer that contains no blood vessels. It is made up of stratified squamous epithelium, which contains melanocytes to help produce melanin. Melanin helps to produce color and helps with protection from sun. The layer of skin also contains keratinocytes, which is where the production of keratin occurs. This helps with the protection of the skin. This layer helps to provide a waterproof barrier, helps to protect against infection by being a closed barrier system, and helps to basically keep the underlying layers secured. When we look at our skin, this is where the first layer would be for pressure injuries, and then superficial burns will affect this layer only, and we'll talk a little bit more about burns later in the lecture. For our middle layer, that dermal layer, this is the thicker layer. In this area, this contains blood vessels, nerve endings, hair follicles, different glands like sweat glands and sebaceous oil glands, and then has most of our collagen and elastin fibers found in this area. When we look at the clinical relevance of this is where thermoregulation occurs. Because of that thick layer and the areas of collagen, this helps to regulate temperature. It also is where pain sensation originates. So this is where those nerve endings are found. That most deep or deepest layer of our skin is the hypodermis. This is that subcutaneous layer. This contains adipose tissue, helps with insulation and shock absorption, and contains connective tissue. This is the layer where subcutaneous injections are given, and this would be the area that's significant in burns with severe fluid loss risk. So we'll talk about this later in the lecture as well. Our function of our integumentary system, so I mentioned a little bit protection. So this intact skin helps to create a barrier against bacteria and pathogens, helps to protect against UV radiation or destruction, and helps prevent water loss as well. So it kind of just creates an overall barrier for protection. It also helps with temperature regulation. So through the act of sweating, which evaporation helps cool the sweat off the body, so that helps to cool the body temperature down. Vasodilation helps to prevent heat loss, vasodilation helps the body get rid of heat. So opening up those blood vessels can help get rid of excess heat in the body. And then vasoconstriction helps with heat retention. So this is what occurs when we get cold. So we'll see this a lot throughout the body where we talk about heat stroke, fevers, sepsis, and those kinds of things where different regulatory motions help with temperature regulation. Then we look at sensation. So these are where our baroreceptors and nerve endings are. So this helps with sensation through pressure, temperature, touch, and pain. So we talk about this when we look at neuropathy related to diabetes. There's that loss of that sensation and can lead to damage of the skin or risk for skin breakdown. Fluid and electrolyte balance comes into play with our integumentary system. We will talk about fluid and electrolyte balance disruption related to burns. So that is primarily how we lose a lot of our fluid and electrolytes through our skin, is through destruction of those cells through burns. Most burn injuries will lead to things like fluid shifts, hypovolemia, electrolyte imbalances, and something called third spacing. Our skin is also responsible for vitamin D synthesis. So repetitive UV exposure helps to convert our vitamin D into our body and helps with calcium absorption for our bones as well. Now we talked about integumentary system not just having to do with the skin, it also has to do with hair and nails. So when we look at hair, our hair distribution on our skin helps with things like protection and sensory function. We know loss of hair may indicate different malnutrition or endocrine disorders like thyroid disorders, or medication effects like chemotherapy and things like that. For our nails will tell us a lot about our circulatory system, our circulation throughout our body to our extremities, oxygenation, and so we will see changes in our nails, our integumentary system related to that. Some common integumentary issues that we will see are things like pressure injuries, burns, cellulitis, different kind of inflammatory responses, skin cancers, and different like moles or scales or things like that, growths of the skin. Okay, so we're going to talk a little bit about what is involved in an integumentary assessment. So your integumentary assessment, I'm sure you guys have gone over in your head to toe assessment class, but it involves both inspection and palpation of the skin, hair, and your nails, along with some focused questions that you're going to want to ask your patient. So first, we're going to start with looking at your subjective assessment. This is what you're going to ask your patient. You'll want to ask your patient key questions about their skin. So things like, have they noticed any new rashes, any new wounds or lesions or areas of the skin that are a problem? Do they have any itching, burning, or pain? Any changes in moles or areas of the skin that they might be concerned about? Any drainage, excessive sweating, or anything like that that could lead to moisture damage of the skin? Have they been exposed to any new chemicals or new products in the house, things like soaps or laundry detergents, things like that? And then do they have any history of any disorders that could contribute or cause risk for skin breakdowns or things like that related to diabetes, vascular disease, immobility, use of medications like chemotherapy or drugs that can inhibit growth or growth or changes in the hair or nails, and then any use of steroids. So those kinds of things. So your high risk disorders would be things like diabetes, immobility, use of steroids or things that can cause that thin, frail skin, medications like chemotherapy that can cause changes in hair and nails. So doing a really good assessment, asking your patient good key questions can give you a lot of information. Then you'll move on to your objective assessment. So this is done in your head to toe assessment. This is what we observe. And remember, your integumentary system encompasses the entire body, so all of the skin in all of the areas of their body, their hair, and their nails as well. So remember, toenails, fingernails, skin, hair that covers the entire body, as well as their head and areas like that. So don't be afraid to ask your patient to assess the skin in their private areas, like under their breasts, under their armpits, in their butt cracks, and things like that, because a lot of patients can hide disorders in that area. So it's really important to make sure we're assessing head to toe their full integumentary system. So first we're going to look at their skin colors. So we're looking to assess to make sure that their skin is normal color for their ethnicity. We are looking for changes in the coloring. So things like pallor, this is a paleness or loss of color. This can indicate things like anemia or shock. We want to look for cyanosis. This can be a bluing or a graying tinge to the skin. This is indicative of loss of oxygen or hypoxia. When we look at patients with liver dysfunction, we might see a yellowing of the skin. We can see this in the skin, the sclera of the eyes as well, and the palms of the hands and feet. So this is a yellow coloring called jaundice. We might notice some redness or erythema. This can mean inflammation or infection. And then kind of a purpling or bruising of the skin can indicate bleeding. And this can be, an indicator that somebody is maybe having some internal bleeding. So the color of the skin is really important to assess. Then we'll look at the temperature of the skin. So using the back of our hand, we want to palpate, comparing both sides of the body, making sure that the skin is dry and warm and intact. If it is increasingly warm to hot, this may mean inflammation or infection. If it is cold to the touch, this can mean poor circulation. With that moisture that we're going to be assessing, we want to make sure that the skin is dry. If it is clammy, sweaty, wet, this could be things like hypoglycemia or shock. So we want to make sure that that patient's skin is dry. Now, we don't want it to go too dry, right? Where we're seeing dry, scaly skin. This can be a sign of things like dehydration or hypothyroidism. So it should be intact, dry, with an intact barrier, not too moist, wet, sweaty, but not too dry as well. When we're looking at the skin, we also want to make sure that the texture of the skin and the thickness is normal. With our elderly patients, we might notice a thin, fragile skin. This can be indicative of steroid use as well. If there is a thickened area like blisters or not blisters, oh boy, what's it called? Not blisters. It's like a callus. That's the word I'm looking for. Excuse me. Sorry, my brain just shut off. A buildup of a callus can show a chronic irritation or skin that maybe is, rubbed in a certain area too much. So what we want is a smooth, intact skin, and this is normal for our texture and thickness. We can also check skin turgors. So remember lifting up on the back of the hand to look for tenting. This can be indicative of our hydration status. With that immediate recoil is what we want to see. That is normal hydration. A delayed return back to normal could mean dehydration in our patient. We also want to look at things like edema. So this could be indicative of swelling. So we look at the edema. This would be mild to moderate to pitting edema, depending on the buildup of fluid that's occurring in the body. And this can be indicative of things like kidney failure, heart failure, liver disease, or an inability for that venous to return blood flow. When we are looking at any lesions, so these would be moles or scales or anything like that, when we're looking at those lesions, we'll want to do the documentation or the assessment using the ABCDE rule. This is for moles. This is looking at the A for asymmetry. This is looking at, is the mole equal on both sides? Is it like you draw a line right down the middle of it, does it look the same on both sides, or is it lumpy on one side and smooth on the other? B stands for border irregularity, so the border should be well defined. It shouldn't be blown out and fuzzy. C stands for color variation. That mole should look the same throughout the entire mole. There should be no areas that are darker or lighter than others throughout the mole. D stands for diameter. We want to document and worry about it if it's more than 6 millimeters large, which is the size of a pencil eraser or larger. And E stands for evolving. Has it been changing? Is it bleeding? Is there any room for concern there with those moles? For wounds, we want to look at things like the location of the wound, the length, the width, the depth of it, if there's any drainage, if the surrounding tissue or skin is damaged or anything like that. And then if it is a pressure injury, we can do staging, which we'll talk about a little bit later. We also want to look at hair assessment. So again, the distribution of the hair, the texture of the hair, if there's any hair loss or excessive growth in certain areas of the body. We'll then take a look at the nail assessment. So again, nails should be clear. They should be strong. There shouldn't be any, deposits in the nails. They should be clear and the color of the patient's skin. There shouldn't be any bluish or cyanosis of the nail beds. They shouldn't have any bulbous shape. They should be nice and smooth. So a lack of clubbing, which is called indicative of chronic hypoxia or breathing issues, and that capillary refill should be less than 2 seconds. For your patient, just making sure, again, we do a good physical assessment head to toe, gathering that subjective and objective data from our patient. Okay, we talked about some lesions or skin disorders that we would find when we're doing our assessment. These are broken into two different types of lesions. There is primary versus secondary skin lesions. The difference is based on how the skin lesion developed itself. So for primary lesions, these are original skin changes that are usually caused directly by a disease process itself, whereas secondary lesions are the change in the integumentary system that occurs after that primary lesion due to healing process, the progression of that primary disease process, infection, or healing due to scratching. So primary lesions are the initial skin or abnormality that will be seen. Some common primary lesions to be aware of would be things like macules. A macule is a flat, non-palpable color change area. This would be an example, would be a freckle. There are patches, so these would be larger flat discoloration areas. An example of this is vitiligo, so that's a change in that coloring of the skin. There is papule. So these are small raised solid lesions. An example of this would be acne. There is plaque. So plaque is an elevated lesion that has a flat topped area. Excuse me. An example of this would be found in patients with psoriasis. There is a vesicle. So these are small fluid-filled blisters. Patients with chickenpox or herpes simplex virus could be showing a vesicle example. You have your patients with a pustule. So these are pus-filled lesions. An example of this would be an infected acne area. There is a wheal. So wheals are typically transient, means they come and go. These are raised areas that are oftentimes due to edema or the infectious disease process. So an example of this would be like hives. Then you have nodules. So these are solid, deeper lesions. These are oftentimes under the skin and larger than 1 centimeter, and these would be an example of this would be like a lipoma underneath the skin. For your secondary skin lesions, again, these often result from either scratching, healing, infection, or an evolution of a primary lesion itself. So some common secondary lesions we see are ulcers. So these are a deep loss of epidermis or dermal layer. An example would be your pressure injury. A fissure, so fissures are a linear crack in the skin. This can be related to athlete's foot or a healing of the skin with that center part crack in the center. Then we have scales. So scales are can be look like flaky skin that sheds or flakes off. Your erosion, this is where there is a breakdown of the skin. We oftentimes see this in chicken pox after the patient has scabbed over. So kind of that scabbed area that's dry and covered, but no longer having any drainage coming from it. There is lichenification. So this is a thickened skin area, oftentimes from chronic scratching. So we see this a lot in our liver failure patients who have a lot of itching and things like that. And then atrophy. So these are patients where their skin starts to kind of dimple in and look like it's a loss of skin tissue itself. So again, your primary skin lesions are the problem itself. Secondary is what happens to the problem. So, chickenpox vesicle is the primary problem. You'll see that open, kind of liquid filled bubble or sore, and then the crusted scab afterwards, where it starts to heal up and can be caused from scratching, is your secondary skin lesion. For your diagnostic tools, so many skin diagnostic tools can help to identify different reasons for a skin disorder. If there's any infection or inflammation process that's occurring, they'll look at whether it's a malignant or benign area of skin through like moles and things like that. If there's a systemic disease manifestation or if it's an autoimmune or allergic reaction. So we're going to talk a little bit about these diagnostic tools. So the first one is a skin biopsy. This is your most common diagnostic tool. This helps to look at whether it's an inflammatory or autoimmune disorder related cause, if there is skin cancer or any type of problem with that skin. It is used to evaluate suspicious moles and to help look at chronic rashes that could be there. So there are a couple different types of skin biopsy. There is a punch biopsy. This is where there is a circular blade. It's kind of like a hole punch where they will remove a full thickness sample. This is looking at the different layers of the skin to look at where maybe a mole is at related to potential skin cancer. There is a shave biopsy. So this is more of a superficial biopsy. That blade just goes basically right through that epidermal layer on the outside and removes superficial lesions. There is also an excisional biopsy. This is where an entire lesion is removed. This is often used for our suspected melanoma. This is where the mole or the lesion itself is removed, and then a surrounding area of the skin is removed as well. And so this is used with a scalpel. There is a culture insensitivity. So this is where we will look for antibiotic sensitivity. We're looking to use it for diagnostics with non-healing wounds. Anything where we have purulent drainage or any drainage from the skin, we would take a culture of that and grow it and see what grows from it and look at which antibiotic would be sensitive to the growth. These are usually used to identify bacterial, fungal, or viral infections. And so we can do that. Main thing with this for our culture insensitivity, we want to make sure to obtain that specimen or the wound swab or the skin swab before starting any antibiotics. This would be a clean, sterile technique, making sure to clean the wound prior to swabbing, just to make sure that we get the actual wound and not any bacteria that's growing just in the exudate itself. We also have a Woods lamp examination. So this helps to detect fungal infections, evaluate bacterial infections, and can light up certain organisms under that UV light. So basically the fungal infection is kind of swabbed or injected with something that will light up under the UV light if it reacts to the fungus infection, and we'll see that light up under the UV light. Patch testing helps with diagnosing allergic contact dermatitis. So what they do is they will introduce the skin to certain allergens like bee stings, pollens, peanuts, those types of things, in the area of the back, and they look for wheals to occur or hives to swell up, and to see what the skin reacts to in relation to the allergen. Typically, this is done over about 24 to 48 hours. This is often done in a dermatology's office, and so they will look for the use of pollen in relation to allergy detection. So these are some of the most common diagnostic tests that we see for skin disorders, and just to be aware of that you'll see out in the facilities. So when we look at normal versus abnormal integumentary findings, the first thing we want to do is understand what normal is. So we want to make sure that we have an even skin tone that is appropriate to our ethnicity of our patient. We should not have any unusual discolorations. Skin should be pretty consistent throughout all over the body. There may be slight redness over pressure areas, but that should resolve pretty quickly. Abnormal findings that we might see again would be things like pallor, that lack of blood flow. This can indicate anemia or shock. Cyanosis, which is that blue or graying color that can indicate hypoxia. Jaundice, which is that yellowing color indicating liver dysfunction. Erythema, which is a redness that can occur. This can be related to inflammation or infection. Petechiae would be related to a platelet disorder. So this is a pinpoint rash on the body, and basically what it indicates is a breaking of the capillaries underneath the skin. So this would be indicative of a platelet disorder or a bleeding disorder. Mottling is what is called where there is poor perfusion related to shock. This we can see in some disease processes like Raynaud's disease. We'll see mottling of the skin where the skin turns super white in some areas and red in others, and it's kind of a blotchy skin. This can occur in our patients who have shock, where we give medications like vasoconstrictors or pressors in the ICU, where that blood will shunt and kind of disappear in certain areas. But mottling is kind of a splotchiness of the redness and pallor related to the blood flow underneath the skin. Normal temperature, again, should be warm and equal on both sides of the body. What we should not see is any extremely cool extremities, which can mean poor perfusion or shock, any hot localized area, which can be indicative of infection, or generalized warmth of the body, which could be indicative of a fever. We want our skin to be dry, so not too moist or not too dry, but it should be normal moisture. So any diaphoresis or sweating could be indicative of hypoglycemia, an MI, severe pain, shock, those kinds of things. It should not be clammy, and it should not be very super dry. This can be indicative of dehydration or hypothermia. Our skin turgor should be normal. That skin should return back to normal immediately after pinching. There should not be a delayed in recoil, which can be indicative of dehydration, or tenting related to that fluid status. This is less reliable in older adults since that subcutaneous level of fat is gone, and so that skin tenting may be less reliable for hydration status in your elderly patients. We also want to look at edema, so make sure there's no swelling. Your extremities are symmetrical sizing on both sides of the body. If we see any unilateral swelling, this could be indicative of a blood clot. So if one calf is larger than the other, we may be thinking blood clot. We want to see no edema. This can be indicative of heart failure, renal disease, blood clots, things like that. So we don't want to see any unusual swelling on one side or the other. We also want to look for we want to look at lesions, making sure that they don't have any suspicious moles. Their skin is completely intact. There's no areas of open. Abnormal findings, again, would be any lesions or suspicious moles that follow that A, B, C, D, E assessments. So use that to rule out any melanomas. We would want to look for any non-healing wounds, any ulcers, any areas that have drainage, especially with odor, and any changes to the skin itself that might be indicative of disorders. And then hair distribution. It should be evenly distributed, should have the appropriate texture. What we're looking for is to make sure the patient does not have any thin, brittle hair or hair loss in patches or areas that it should not be. And then our nails. So our patient's nails should be pink. They should have good capillary refill, less than 2 seconds. There should not be any clubbing. Delayed capillary refill can be indicative of poor perfusion. Brittle, thin nails can be indicative of an iron deficiency. Cyanotic or blue, dusky nails could be indicative of lack of oxygen or hypoxia. And then clubbing could be a sign of chronic breathing issues. If we do find any wounds, we want to make sure we assess them, make sure that they have normal healing, there's no odor, minimal drainage. We are looking to make sure they do not have any purulent drainage, any redness that's spreading or increasing, pain with worsening, worsening pain, any worsening fever or increased warmth is what we're looking for our normal patient's assessment. So our skin is often called a window to our internal health. It can tell us a lot about how our insides are doing. So with our patients, some systemic disease cues that we need to be aware of would be related to the different parts of the body. So when we look at skin disorders related to the cardiovascular system, we might find changes in the coloring of our skin. So again, that's cyanosis, pallor. We want to make sure that it's warm because warm means blood flow. So if we have any cold, cool, pale skin, this could be indicative of a cardiovascular disease. Again, that edema. So if we have cardiac dysfunction, we may have dependent edema or fluid retention as well. When we look at the respiratory system, again, we'll look for things like cyanosis or clubbing, which can be indicative of respiratory or lung issues like COPD or low oxygen levels. We talked about endocrine disorders like diabetes, which can cause delayed wound healing, ulcers, an increase in infections, neuropathy, changes in sensation. We also talked about hyper and hypothyroidism. So hyperthyroidism tends to have warm, moist skin, fine hair, and increased sweating, whereas hypothyroidism would have cool, dry skin, coarse hair, and a thickened buildup of that skin. Renal disorders or kidney disorders, these would be things like dry, itchy skin, pale appearance, uh, what's called a uremic frost. So if you see that bottom picture there, the guy's forehead kind of has that white, frosty look to it. This is a buildup of the uremic calcifications in the body due to the kidneys not working. So that's called uremic frost. Patients may have a pale appearance or pallor. This is due to the kidneys maybe not creating red blood cells effectively, leading to anemia. For our hepatic or liver disorders, this would be patients that may have jaundice or angiomas. So that little top right corner is a spider angioma. This is due to clotting disorders, bruising, pruritus, those kinds of things can be related to the liver disease and hepatic disorders. For your autoimmune disorders, so if you look in that top left corner, you see the little rash that's on her face. This is a butterfly rash. This is indicative of an autoimmune disorder, lupus. Patients with autoimmune disorders like psoriasis may also have plaques with silvery scales or chronic inflammation. And so this would be autoimmune disorders that we might see changes in the skin. Hematological disorders, these would be things like anemia, again, pallor with brittle nails, or thrombocytopenia, which we'll talk about in our hematology lecture. These patients may have petechiae, that broken capillary rash type of a thing, or purpura, which is broken blood vessel areas of bleeding that you might notice for hematological disorders. For your patients, they may have nutritional deficiencies. So patients with like an iron deficiency or vitamin C deficiency may have poor wound healing, brittle nails, pallor, or bleeding gums. So we might see different things come out in the integumentary system. related to disorders that we have in all of the systems of the body. So it's important to know those information, know what your patient has as far as their history in relation to their skin. Okay, so we're going to talk about pressure injuries. So pressure injury is an area of skin damage in a localized area, usually caused by prolonged pressure, but it can be caused by shears, frictions, or excessive moisture. Usually occurs over the bony prominences. So if you look there on the picture, those red areas are the bony prominences that are at higher risk for skin breakdown. But this is due to a sustained pressure that compresses blood vessels. And so that blood flow decreases and leads to an ischemia of the tissues. And so over time, that tissue does not get enough blood flow, does not get enough oxygen, and then cell death occurs. And so this tissue starts to necrose or break down. Skin breakdown can occur very quickly, so it can occur over hours. So it's not just, for long periods of time, but these are mainly found in patients that are immobile, combined with other risk factors. So some of the other risk factors we have are advanced age, malnutrition, poor perfusion, or diabetics who have poor sensation, poor blood flow, decreased sensation, or increased moisture related to sweat, urine, or stool for our patient. The way that we look at these, they can be staged, and we will talk about this in the next slide. But this is related to which layer of skin is impacted. Now, for wound care, that is a specialty. So oftentimes, depending on your facility, they will have a wound care nurse stage the wound. Regular bedside nurses won't stage it, but just figure out your hospital policy or facility policy on who is responsible for staging the wounds. It's really important as a bedside nurse to understand where the skin breakdown can occur and what risk factors are for it, and then what nursing interventions you can do to help decrease skin breakdown. So number one for skin breakdown for your nursing intervention is prevention. So this is our most important nursing role. So in order to look at our patients, we do a good skin assessment, making sure they don't have any breakdown, and then do a mobility assessment. Can they get up? Can they walk? Are they turning themselves, repositioning themselves, moving in bed, moving in the wheelchair, or are they just sitting in one spot and not really getting their circulation to all their areas of their skin? So most important nursing role is prevention. So we're going to reposition. Repositioning every 2 hours at a minimum for patients with intact skin. If they have broken skin or any signs of breakdown or impaired skin circulation, you will increase that to every hour. We want to use support surfaces, so we may use things like pillows, different cushions, heel protectors, specialty mattresses, those kinds of things to help with giving a little bit extra barrier to that pressure. Skincare is really important, so managing incontinence, making sure their skin is clean and dry, keeping the moisture off of their skin, and utilizing barrier creams. Making sure nutrition-wise we get enough protein, vitamin C, and zinc. This helps with wound repair, so it is really important for them to get adequate protein and vitamin C. This helps with that cell creation to replenish the skin. We want to do a good assessment of our patient, and we will talk about how to assess those pressure injuries on the next slide. But we want to make sure we assess the location, the size, any drainage, the surrounding skin, presence of tunneling or undermining, and then their pain level during treatment. For our patients, making sure that we consult a wound care nurse if we find that they have any presence of any skin breakdown so that they can get correct treatment started. Okay, so we're going to look a little bit about pressure injury staging. So this occurs over a bony prominence or an area of pressure, and it ranges from stage 1 all the way to stage 4. There is also 2 stages. One is called unstageable and one is called deep tissue injury. So we'll talk a little bit about each one of these stages. So stage 1, which you can see there in the 6 pictures, it's the top left one. This is an area of intact skin, so that means no area of the skin is broken, so there is intact skin, but there is a non-blanchable redness. So that means when you press on the area of redness and let go, it does not change color to white. That redness is there the entire time. This area may feel warmer or firmer than others, but this is an early warning sign that we have a pressure injury started. So this patient, we need to increase turning, put some barrier cream on, keep them off that area, and really reposition them frequently to decrease the risk of this advancing to the next stage. Stage 2, which is that top middle box, this is an area that has partial thickness skin loss. So this is where the skin has opened and you will see a reddened pink area, but it's that outermost layer has now been opened. So this is a part that is exposing the dermal layer. For this, it may have a pink or red wound bed, may be open or shallow wound, but for the most part, all you're seeing is that first layer of skin. For our stage 3, that is that top right corner, this is an area that has full thickness skin loss. So this layer has now, or this wound has now gone to the next layer. So we will have adipose tissue visible. So on this one, you can see that whitened area that kind of looks like a white pus area. That's actually adipose layer. This has the dermal layer as well. So that pinkish red, and it is open. So that's an open sore. That is a stage 3. For your stage 3, there is no bone or tendon exposed. Okay. So for our stage 4, this is that bottom left corner. This is where that is a full thickness tissue loss. We are to that most deep layer of the body. This is where bone, tendon, or muscle is exposed. So you will see that it goes all the way down. There's an area of kind of whitish yellow. That's your adipose layer. You can see that bright white breakdown there in the center of the wound. That would be down to the bone area. And there's some muscle layer showing there as well. So stage 4 is bone, tendon, or muscle is exposed. For your next area there, the bottom middle, this is called unstageable pressure injury. So there is an eschar right there in the middle. That is that black layer of skin. That's actually black skin or dead skin. And so we can't fully understand or see the full depth of the wound. So for an unstageable wound like this, what we would do is we would typically do a debridement where we would either go in and scrape this out with a scalpel so that we can get that dead skin out of there to really see how deep that pressure injury goes. So a unstageable wound is covered by a slough or an eschar, which is a deadened skin, and that cannot be determined for how deep it goes. For your deep tissue injury, that's that bottom right corner. A deep tissue injury oftentimes has a purple or maroon discoloration. There is intact skin typically, so it kind of looks like almost like a blood-filled bruise or blister. And this is where it is indicative of a deep layer injury that's occurring. This can rapidly deteriorate and become an open pressure injury. So for this one, we would want to take the pressure off of the patient's skin or heels, which is where that injury is at, is on somebody's heel. And so we would want to let the body heal itself and hopefully decrease the risk of it opening up and becoming an injury. So those are your injury staging. Stage 1 is non-blanchable, it is closed, and it is red. Stage 2 is open skin, but it's just that outer dermal layer. Stage 3 has exposure of the subcutaneous or fat layer of the skin. Stage 4 has deep thickness, and we do see adipose tissue, muscle, tendon, and bone in those stages. An unstageable is covered with eschar or slough to where we cannot see that wound bed, and the deep tissue injury is oftentimes closed with a deep purple or maroon red discoloration. So bacterial skin infections occur when bacteria enters into the skin, oftentimes through things like cuts or abrasions, breakage in the skin, surgical wounds, IV sites, insect bites, those kinds of things. Our most common organisms or bacteria that we see that enter in are things like Streptococcus aureus or Streptococcus pyogenes. And this is typically MRSA that we see that enter in. So for example, this patient here in the picture looks like they have a little bit of cellulitis. So this is an infection of the dermis and subcutaneous tissue layer. What you'll find oftentimes is erythema or redness, warmth, swelling, tenderness, and usually will have some sort of infectious or inflammatory process like a fever. This can spread rapidly into the blood and lead to sepsis. So for our patients, the main thing we want to do is to mark the area of border, so kind of mark the edges of that redness to monitor to see if it spreads, gets worse, do any type of um, uh, swabs on the skin. Your culture and sensitivity is what I'm trying to say. So when we swab the skin or any drainage and then give antibiotics. So it's really important to get them on antibiotics quickly for this bacterial infection. We want to monitor for any worsening symptoms. Oftentimes we utilize contact precautions since it can be spread, but those kinds of things we would want to assess for. Different other bacterial infections of the skin, along with cellulitis, would be things like impetigo. So this is common in children. These are usually honey-colored, crusty lesions around the mouth and face area. We typically treat this with antibiotics as well. Folliculitis, so this is an infection of the hair follicles. This can be small red bumps throughout the skin, usually all over the skin area on the arms or legs. This is usually from shaving or inflammation from hot tubs. So this is an inflammation or infection of the hair follicles itself. We can also have an abscess. So this is a buildup of pus in a localized area. Oftentimes the wound is draining purulent drainage. It may be a bulbous or bump underneath the skin, super painful, super warm around there, and just look like a big giant, kind of like a boil or a big giant zit is what an abscess would look like. For this treatment, antibiotics is important, but we also want to do an incision and drainage. So those patients would have a surgical scalpel, cut it open and drain that incision. We might do packing or things like that in the wound to make sure that it drains out appropriately and we get all the infection out from under the skin. For our medical emergencies, so one of our bacterial infections that's a medical emergency is necrotizing fasciitis. So this is a bacterial infection that can be from a breakage in the skin. I had a patient who was an elderly patient, and she reached into her cabinet to get a plate out of her kitchen cabinet and scraped her arm on a screw that was, sticking out of her cabinets. And within about 6 hours, her tissue on her arm started to just basically break down. She came into the ER and you could almost see her bone. It was that rapid of tissue destruction. So this is very quick. The skin actually will start to necrose and break down, and it can lead all the way to the bone. So this is a rapid tissue destruction. Pain is severe. The patient will have oftentimes skin discoloration surrounding the wound, crepitus around in the skin, and may have signs of systemic toxicity. So for this patient, antibiotics is really important, and they may need surgical intervention to go and clean out the wound itself and remove some of that necrotic skin. For your bacterial infections, just remember that skin barrier is disrupted, bacteria enters, and that inflammatory process begins. This can lead to white blood cell migration, so it can lead to swelling and pus, increased blood flow, redness, warmth, skin breakdown, and those types of things. It can become severe, so it can lead to sepsis, it can lead to osteomyelitis, which is an infection of the bone, and it can lead to severe tissue necrosis. So for your nursing assessment, make sure you're looking for any redness, warmth, swelling, drainage, patient's pain level, and look to see if we need to do any antibiotics for treatment. Remember, culture before antibiotics, do wound care, pain management, and monitor blood glucose levels in our diabetic patients. So viral skin infections are a breakdown in the skin that has a viral infection. So these patients produce characteristics like lesions, like rashes, pustules, vesicles. For these patients, antibiotics are not effective because it is a viral infection. So oftentimes these patients will need uh, um, symptomatic care and then antivirals to manage treatment. So some common viral skin infections would be things like herpes simplex, so HSV1 and HSV2. This is where an individual may have clustered vesicles, burning or tingling before an outbreak, and painful lesions. This can be in our oral area or it can be in our uh, uh, vaginal or penile area as well. Viruses can become latent in the nerve areas and can reactivate during stress or illness. For these patients, we can do symptom management like pain control, hydration, and things like that. And they can also take an antiviral medication. So these are medications that end in VIR, like acyclovir or valciclovir. So ends in VIR, it's an antiviral medication. Another viral skin disorder that we see is varicella or chickenpox. This is where the patient will have a rash in different stages, whether it's a macule, papule, vesicle, or crust. This is transmitted via airborne and contact, and we often see this in kids or individuals that have not had the chickenpox before. For our patients that have herpes zoster or shingles, this is a reactivation of the varicella virus. So if you've had chickenpox before, you can have shingles later in life. Usually this is in our older patients, in individuals who have had chickenpox as a child. They will oftentimes have a painful vesicular rash that's unilaterally, and it does follow a dermatome or an area of nerve endings. So this is really painful, has a lot of pain related to it. So these patients would be on contact precautions and have pain control. Then there is HPV or human papillomavirus. This causes warts. This can be on the skin or this can be in genital areas. So common warts, plantar warts of the feet, or genital warts. Certain strains can lead to cervical cancer. So it's really important to understand risk factors for HPV and do screenings for that as well. For our patients with viral infections, so again, that virus enters in through the skin, invades those epithelial cells, replicates, and causes cell destruction, which can lead to vesicles or rash. Some of these viruses, like HSV, can remain latent in our nerve cells, so they can come out during periods of stress. So risk factors for this are individuals who are under high levels of stress, who may be immunosuppressed, malnutrition, or have lack of vaccinations. For our nursing assessment, we want to look at the type of lesions, the distribution pattern, if there's any presence of pain or itching. We want to give antivirals if indicated, do symptom control, and prevent secondary infection. We would utilize isolation precautions if required, things like airborne or contact for varicella and shingles. Once the vesicles are scabbed over and no longer producing any discharge, usually that risk for transmission decreases significantly. Okay, now we're going to talk about fungal and parasitic infections. So these infections are caused by uh, dermatophysites or yeast that thrives in warm, moist environments. So our Candida species is oftentimes what we see, or our tinea infection. So tinea is ringworm. This is based on the location that it's named. So, for example, tinea capitis or capitis is your scalp. So this would be ringworm on the scalp. Tinea pedis is athlete's foot. Tinea corporis is ringworm on the body. Your assessment findings for tinea or ringworm is a rash in a circular shape. So it's like a circle rash. That's why it's called ringworm. They would have raised borders on that rash and may have itching. Our risk factors for this are individuals who utilize shared showers or wrestling mats, yoga mats, those kinds of things, sweating, and transmission through contact of those surfaces. For our patients with this, we would do a topical antifungal or an oral antifungal, depending on what type of infection this is. For your candidiasis, so this is a yeast infection. These are really common in your patients in the hospital, especially in like warm, moist areas like underneath the breast, underneath pannus skin folds, in the groin area, and then in the mouth. So we can get oral thrush as well. For these patients, they will oftentimes have a red, moist rash. They may have white patches, especially in that oral thrush area, and they may have little lesions throughout. Your risk factors for thrush or candidiasis is going to be diabetes, people who are on antibiotics because this is an opportunistic infection, or people who have immunosuppression. For your parasitic skin infections, these involve organisms that live on or inside of the skin. So one of our most common ones is scabies. So scabies are little mites that burrow into the skin. This can have patients complaining of intense itching that are worse at night, rash between fingers, wrists or waistline, or have areas of burrows in the skin that look like little lines. This is a skin-to-skin contact transmission. Your treatment is making sure that we use permethrin cream and cleaning your household linens and everything in hot water using bleach. We also have a parasitic infection that is head lice or pediculosis. This is where individuals will have little tiny nits attached to their hair shafts and little tiny bugs. The patient will complain of itching. For this, your treatment is permethrin shampoo, combing out those eggs, washing bedding and clothing in super hot water. For your patients with parasitic or fungal skin infections, again, just making sure you do a good head to toe assessment, also paying attention to the hair area as well. And this is just a review of the ABCDEs of skin cancer. So again, A, looking for asymmetry. So both sides or all edges of the mole or lesion should be symmetrical. B stands for border, so it should have a clean cut border. You should see all the edges of the border. It shouldn't be blurry or blown out in any area. C stands for color, so it should have the same color throughout. D stands for diameter, so we want less than 6 millimeters, so smaller than the size of a pencil eraser is what we want, or is at a decreased risk for skin cancer. So the bigger it is, the higher risk for skin cancer it is. And then E stands for evolving. Is it changing? Has it started bleeding? Has it changed shape or had any changes through there? For your patients, some patients will have plastic surgery or cosmetic surgery related to skin breakdown. So if they have giant wounds like stage 4 D-cubes that we've treated, they may have like skin flaps or skin transplants or things like that. We might see it with burn patients. They may have plastic surgery or things like that to help the decrease the look of the burns or the scars. For those patients, you want to make sure you do pre-op nursing interventions like informed consent, do a physiological assessment, make sure they understand the risks and the outcomes. For post-op, main things are looking at infection prevention, wound care, making sure to support. They may need multiple surgeries, especially if it's related to a burn or things like that that are severe trauma to the skin. So this may be kind of a lifelong thing where they're working towards getting that appearance of that skin to be a little bit more cosmetically pleasing. Okay, so we are going to talk about burns. So a burn is tissue injury caused by chemical, electrical, radiation, or thermal, meaning fire and steam. Burns don't only affect the skin, but can also ultimately affect the fluid balance, electrolyte balance of your patient. It can impact cardiovascular, respiratory, and immune systems. So severe burns are systemic injuries, not just skin injuries itself. When we look at burns, we look at the degree of burns. So there is first degree, second degree, third degree, and it depends on how deep or how much skin layer is involved. For your first degree burns, this is a superficial burn. This is where the epidermis only is impacted. This leads to a red, painful area, but no blistering occurring. This oftentimes heals without scarring, and our skin regenerates. So an example of a first degree burn is typically our normal sunburn. A second degree burn is a partial thickness burn. This is where the epidermis and part of the dermis is impacted. Oftentimes our patients will complain of blisters. It will be moist and red and will have severe pain associated with it. So this is the one where you burn yourself on the stove and it creates a little fluid-filled blister. For our third degree, our full thickness burn, this is where the entire epidermis and dermal layer is destroyed. This may appear white, leathery, or charred. Oftentimes this is painless because nerve destruction is impacted as well. So these are patients who may have burns related to fire or things like this that we have for severity of that third degree burn. When we look at estimating how much surface area is burned, we will use the rule of nines. So the rule of nines estimates the percentage of body surface that is burned in adults. So when you look at the picture here, we will be talking about the rule of nines in adults relating to the percentage of skin that is broken down or burned. For your adult, when we look at the head and neck, that is 9% of the body if the patient was burned. Head and neck is 9%. Each arm is 9%. Each leg is 18%. The anterior trunk or front of the chest and stomach area is 18%. The posterior trunk is 18%. And the perineal area is 1%. If the patient has burns to the head, neck, chest, or face, your main thing related to that would be issues with respiratory status as well, since that burning can be in the airway as well. So that's an important thing that they like to test on. For our systemic effects of burns, so first we worry about fluid shift. So burns can cause capillary permeability. which causes the fluid to leave the bloodstream and can cause fluid to occur in that third space area. Hypovolemia develops, and so our patients are at risk for electrolyte changes. So oftentimes with cell destruction and fluid shifts, your patient will be hyperkalemic and initially, and then as that fluid starts to shift, it will change to hypokalemia. So cell destruction, breaking down of the cells leads to hypokalemia after that fluid shifts. Since burns destroy our protective barrier, this puts them at high risk for infection. So for your emergency priorities, again, looking at airway, breathing, and circulation. For our burn patients, first we want to look at their airway. So we're looking at, did they have any burning of the face, chest, or neck area, looking for singed nasal hairs, looking for soot in their airway, in their nose or their mouth, looking for a voice hoarseness that could indicate airway swelling. Stridor or airway swelling can occur rapidly, so we would want to assess for airway clearance. Then you'd want to look at breathing, so monitor for inhalation injury and apply oxygen to really get that oxygen circulating. And then C is for circulation. This is where we will do 2 large bore IVs and fluid resuscitation. I'm not going to teach you the Parkland formula, the fluid resuscitation. You guys will go through that a lot in complex care, but it is important to understand the rule of 9 for burns. So if I gave you an example of a patient who was burned to the entire left arm and the anterior trunk, I would ask how much is the total area of burn to the patient. So anterior trunk is 18% and the left arm is 9%. So that would be a total of 27% burn. So rule of 9s is important to know. And then just understanding the phases of that care. So airway, breathing, circulation, understanding that burns cause a hypovolemic fluid loss. So your patient will be hypokalemic and have a loss of fluids. So a lot of fluid hydration is expected. So lots of IV fluids post-burn. Again, here are your priorities for burns. So remember, loss of skin barrier leads to fluid loss and infection risk. They are having a huge capillary leak due to that tissue damage. So there may be a massive inflammatory response. Third spacing occurs, so the patient becomes hypovolemic, has electrolyte imbalances like hypokalemia, and increased metabolic demand since the cells are trying to regenerate. We will use IV opioids for pain. They will have severe pain. Sterile wound care because we want that skin to regenerate and decrease the risk for infection. Early antibiotics, and then hydration via IV replacement. So paying attention for your complications, A, B, C's, and then D, the rest of it, you have to remember this can lead to significant scarring, psychological distress, pain, and things like that. But make sure to pay attention to the A for airway, B for breathing, oxygenation, C for circulation, loss of fluids, loss of electrolytes, and a breakdown in our barrier. So they may have changes in temperature and risk for infection. So remember your complications of burn injuries and your priorities, A, B, C, Ds. So A, airway, B, breathing, C, circulation, loss of fluid volume leading to dehydration, hypothermia for temperature control. We lost our barrier, so we're at high risk for infection. We also have Ds, so high levels of pain, psychosocial stuff due to scarring and skin loss. And so we want to pay attention to those. So A, B, C, D, E's for or A, B, C, D's for your priorities. For our nutrition, remember, in order for skin to regenerate itself, we want to increase protein, increased vitamin C, and increased vitamin mineral supplementation, like biotin. We want to monitor weight and healing process, watch for dehydration, increase hydration for patients with burns, and then we may do early range of motion and splinting to help prevent contractures. As the skin heals, it can build up scar tissue, which can cause the muscles to contract in different areas. So splinting, use of massaging and things like that can help prevent contractures that build up from scar tissue.